So the first case is a 17-year-old right-hand dominant male varsity football player who presents to my office about 4 days after trying to block a punt during the football game. He tried to block it with fully extended digits, but unfortunately brought his hands down a little too soon and sustained an axial loading impact to a fully extended digit, resulting in his injury, which I will show shortly. Interestingly, this patient 2 years prior also sustained a left small finger P1 condylar fracture involving the PIP joint, also from a football injury that underwent open reduction and internal fixation by an outside surgeon, which was complicated by loss of reduction and fixation and required multiple revision surgery without success, and now has permanent loss of PIP range of motion of the left small finger. His injury radiographs are as shown here. If you focus on the middle finger, he has a middle phalanx base fracture intra-articular involving approximately 50% of the articular surface, as well as the classically described pathognomonic dorsal V sign in line with essentially what is a pilon fracture of the middle phalanx. Additionally, if you take a look at the small finger that is visible in all three views, he's had previous surgery with 2 screws, as well as resulting avascular necrosis of the condyles of the proximal phalanx, and now a permanent fixed flexion deformity of approximately 90 degrees. He is seeing me primarily for the middle finger acute injury. So as discussed, his diagnosis is a left closed middle finger, middle phalanx intra-articular base fracture dislocation, pilon fracture of the PIP joint, involving approximately 50% of the articular surface with comminution. And one of the advantages of my office is that I have an in-office fluoroscopy where I was able to perform a digital nerve block and attempt close reduction and dorsal extension block splinting of the patient, as the patient and his family were very hesitant to undergo any kind of surgical management given the poor outcome of the other digit 2 years ago. One of the advantages of an in-office fluoroscopy is that I can show the patient and his family that while as surgeons we know that a 50% involvement of the articular surface is unlikely to provide any stability, I can provide a live fluoroscopic image and exam for the patient and his family. And in his case, I was unable to maintain any level of stability at any point of flexion splinting for this patient. As such, he was indicated for surgical management, and we have many options for this injury pattern. You can perform an open reduction internal fixation with various sizes of screws, such as 1.0 and 1.3 millimeter screws. Volar plate arthroplasty has been described. You can do a dorsal extension blocks pinning, a closed reduction with a dynamic external fixator device, or a hemi-hamate arthroplasty, and these are all options for this case. In terms of surgical considerations for this case specifically, given the significant amount of comminution seen on X-ray, my experience has been that anytime we perform an open reduction for this fracture pattern, the pieces are already much smaller than what they appear radiographically. And in his case, there was already comminution, and as such, I was expecting that if I were to open this patient, I would have significant, essentially bone dust and no bony blocks for fixation. And given his experience with the small finger, I was worried that I would not be able to adequately perform an internal fixation. A volar plate arthroplasty is a reasonable option, and the same with dorsal extension block pinning, but neither of those, I think, in this case would have been powerful enough to hold the joint as well as allow for the most adequate restoration of the joint line. A hemi-hamate arthroplasty is a very powerful arthroplasty and technique for this injury, but in terms of future planning, I wanted to save the hemi-hamate arthroplasty as a salvage option should my primary fixation fail or not work as well. So ultimately, the patient and I and his family decided on a minimally invasive, soft tissue friendly procedure, and he was indicated for a closed reduction with application of a dynamic external fixator. And there are many different techniques described in many different constructs, such as the Slade X-Fix or the Suzuki X-Fix. But I'm a little bit partial to the X-Fix as described by Badia and Orbe, which is a bit simpler and does not require any sterile rubber bands or gum bands. And it's a little bit easier for the patient to maintain and does not run the risk of having the rubber bands break. So these are the immediate postoperative fluoroscopic views for this patient. As you can see, he has the dynamic external fixator with these K-wires, smooth K-wires placed at the isometric point of the proximal phalanx condyle, as well as the middle phalanx condyle. And he has a longitudinal custom curved dynamic external fixator device, which is now holding the joint distracted, but not overly distracted, while maintaining the articular surface of the PIP joint, and leverages ligamentotaxis to restore the volar articular surface. As you can see in my fluoroscopic views, I actually added a dorsal extension block pinning, and this was added after application of the dynamic external fixator, as when the patient extended past 20 degrees of extension, I started having a little bit of displacement of the fracture site. And as such, this dorsal extension block pinning allowed me to maintain adequate reduction of the joint line and articular surface while still allowing for immediate early range of motion postoperatively. The one caveat with this procedure is they actually have to come back and see you once a week until you take the dynamic external fixator off. And at 1 week, the patient came back with, as expected, no signs of healing. And we continued with the dynamic external fixator and the dorsal extension block. And at 2 weeks, he demonstrated that overall, with some gentle self-directed range of motion, there was no recurrence of dislocation, there was no displacement of the fracture site, and the overall articular surface of the PIP joint maintained its congruence. And as such, I started him on a formal course of hand therapy for early active range of motion, as well as daily pin site care. At 3 weeks, he had minimal healing, but improved range of motion. And at 4 weeks, he comes back with what looks to be robust amounts of healing. And in the office, I actually used the in-office fluoroscopic C-arm to assess the joint stability with all the constructs in place, but by disconnecting the traction and reducing the longitudinal traction and distraction of the external fixator, and ensuring that I did not have any residual displacement or dislocation after disconnecting the traction. And that's really important because what can happen is if they still have some instability, you can just reconnect the dynamic external fixator and continue range of motion with the longitudinal traction in place. But in this case, the patient had significant stability throughout his arc of motion, and both the dorsal block pin as well as the dynamic external fixator were removed in the office. And at that time, he had approximately 45-degree arc of motion, and he was planned for continuing hand therapy. The patient was actually lost to follow-up because the patient thought that he was doing so well that he did not need to come back. I actually called the patient around 3 months because I did not see him in my clinic. And I asked him what was going on, and I brought him back in. Overall, the patient was still working with hand therapy and doing his hand exercise protocols. And these are his latest x-rays demonstrating overall fairly congruent joint line. And interesting, if you look at the lateral, it's not a perfectly congruent PIP joint. But what it looks like has formed is that he has formed fibrocartilage at the area of defect. And one of the advantages of early range of motion is that it does help to mold and remodel fibrocartilage in this region, allowing for this patient to have an overall excellent clinical result, as you can see by his range of motion pictures, where he has an essentially an active range of motion arc of 15 to 86 degrees, but a passive range of motion arc of 0 to 95 degrees of flexion. And now at 3 months post-op, this patient has 100 pounds of grip strength and has returned to benching and bench pressing 235 pounds and has returned to football. So overall, very good clinical outcome for this tough injury. that is often fraught with a long rehab protocol, as well as sometimes insurmountable stiffness. I now want to shift gears to a second case, and this is a little bit up the upper extremity, now at the elbow. This is a 48-year-old right-hand dominant male who fell off his truck and landed onto outstretched hand and extended elbow, trying to break his fall. He underwent an attempted closed reduction in the ER by the on-call team with initial thought of a successful closed reduction, and the report by the radiologist even quotes that this was a completely successful closed reduction of the elbow fracture dislocation, and I will show you that was a mistake. So this is the injury radiograph that the patient had in the ER. So this patient has a classic terrible triad injury, which consists of a radial head fracture in combination with a small coronoid fracture and ulnohumeral elbow dislocation. This is what was read as a successful post-reduction radiograph. And while yes, this is improved compared to the injury film, there are a couple radiographic lines I want to point out, and I think this is a great teaching slide. On the AP view, if you take a look, and if you can see my cursor, the ulnohumeral joint is actually not well aligned. You can see that the coronoid does not articulate with the trochlea in a congruent manner, and there is a slight lateral displacement of the medial edge of the coronoid compared to the medial edge of the trochlea and the medial column. Additionally, you have overlap of radiographic densities in this region, demonstrating that you do not actually have a congruent ulnohumeral joint. And in combination with the radiocapitellar line and lateral displacement of the radial shaft with the lateral column, you can just tell off the bat that on the AP view, this is not a congruent reduction. On the lateral view, it becomes even more obvious as the joint space of the ulnohumeral joint is too wide, and you have ulnohumeral sag at this location, demonstrating that, once again, this is not concentrically reduced. As such, the patient actually went with the on-call team for surgery, which we don't have his post-surgical films, but per the operative note, the on-call team performed a radial head fixation, as well as lateral ulnar collateral ligament repair and open reduction of the ulnohumeral joint, and he was placed in a splint and told to follow up with the orthopedic hands and upper extremity specialist. So once again, the patient had a right terrible triad elbow fracture dislocation consisting of a radial head fracture, ulnohumeral dislocation, as well as a small coronoid fracture, and with the on-call team underwent the appropriate surgery. But interestingly, this is what he shows up to my office in 2 weeks with. This is 2 weeks post-op, and as you can see, this patient is redislocated and has crushed the repair, the fixation of the radial head, and now we have a tough problem. It's interesting, when he came into my office, the posterior slab splint was broken, and he claims that he was just trying to push off his bed to get out of bed to go to the restroom at night and felt a crack. It's unclear exactly what happened, but given this at 2 weeks post-op, the decision was then made that he had a recurrent right elbow terrible triad injury with radial head fixation failure and likely re-rupture of the lateral ligament complex repair and significant gross instability of the elbow joint. And as such, the surgical consideration and plan at this point would be to perform a revision elbow open reduction and convert him from a radial head fixation to a radial head arthroplasty, as well as consider revision of the LUCL repair and possibly reconstruct with a palmaris longus autograft. And this is the key part of the case, is application of the skeletal dynamics internal joint stabilizer. So that's exactly what he underwent with me. I took him urgently, given his gross dislocation and instability and the concern for the development of heterotopic ossification with delayed reduction and fixation of this injury pattern. And I performed a revision open reduction as well as a radial head arthroplasty in combination with a LUCL revision repair, as in his case, the sutures had simply pulled out of the LUCL, and he did have significant robust tissue that allowed for a primary repair rather than a reconstruction. And finally, I augmented this with the internal joint stabilizer. Now, in these cases, there are multiple options that you can do for this procedure to maintain stability, ranging from a external fixator at the elbow, a hinged external fixator at the elbow, or even temporary elbow orthodesis with a large, smooth Steinman pin placed through the ulnohumeral joint to maintain joint congruence and stability. But none of these really provide the ability to perform early active range of motion that this device allows. So this has a smooth bar that you can see placed across the isometric point of the elbow and connects to the ulnohumeral joint and allows you to tension and set your reduction. Now, the key part of this case is that you actually have to get the reduction without this implant. This implant serves only to augment and support the reduction of the ulnohumeral joint and should not be the reducing factor, because otherwise, once you take it off, you're going to have instability once more. But the advantage is with this implant in place and the revision surgery, I allowed the patient immediate active range of motion and active assist range of motion under the guidance of a physical therapist at 2 weeks post-op, because at this point, he only had a 15-degree arc of motion. He comes back to see me 4 weeks later, and at this point, his arc of motion is 45 degrees to 90 degrees, and overall, everything still looks good, but he seems to be developing a little bit of heterotopic ossification. But at this point, it's still fairly immature HO, and the plan is that he will continue with therapy to continue working on range of motion, and his joints still remain congruent. And this is at 3 months post-op, and overall things still look very good. His HO remains fairly immature, but unfortunately the patient sustained myocardial infarction at 2 months post-op from a separate incident and underwent multiple stent placement and initiation of dual antiplatelet therapy and cardiac rehab, and he was actually unable to perform any physical therapy during that 1 month span. But at his 3 month post-op appointment, his arc of motion was 40 degrees of extension to 110 degrees of flexion. And this is through a self-directed exercise program. So initially, the plan is actually to remove this internal joint stabilizer. It's not designed to remain in the body forever, but given this patient's post-operative course and current medical conditions, the decision was made to keep the internal joint stabilizer until he is off of dual antiplatelet therapy and cleared by cardiology, as well as to allow for us to wait for maturation of the heterotopic ossification, so that ultimately in his next procedure to remove the IJS, I can also perform a heterotopic ossification resection and likely elbow contracture release if he needs it. But this is where we're standing at right now with this patient. So in summary, a few key points I want to leave you with is, whenever possible, leverage the effects of ligamentotaxis and minimize disruption of the soft tissue envelope. And this is really crucial, especially for PIP joints and PIP joint fracture dislocations, as those condyles and condylar fractures can really undergo avascular necrosis very easily. Additionally, early range of motion constructs such as a dynamic external fixation and the internal joint stabilizer really helps to minimize the sequela of fibrosis and significant stiffness. And this is really noticeable in the PIP joint and the elbow, which are two joints of the upper extremity that get very stiff very quickly. Thank you all for this opportunity to present.